Good morning, everyone. My name is Major Raul Amin, and I have with me Major Julia Skiles, who's going to be leading the predominant portion of this topic today. This is a two-part series, so if you are looking at this particular video on administrative separations, we highly recommend that you also look at our presentation on medical evaluation boards. Now, in order to do one effectively, you have to be able to also know the other. So essentially, think of this as a part one of a two-part series. I am the psychiatry residency program director at Walter Reed, and Major Skiles is someone that I've served with when I was a division psychiatrist and has a lot of depth and experience when it comes to executing administrative separations in the Army. She's currently a behavioral health officer at the 11th Signals Brigade at Fort Hood, Texas. You also have one of our other colleagues that you'll meet in our medical board video, and that's Captain Lee Hart, and he is one of my resident rising senior. So going to the next slide, these are our disclosures. We do not have any financial or other conflicts of interest. And these views expressed here are our own personal views and do not reflect the opinions of the Army Medical Department, the DoD, or any of our affiliated military units. There's also instructions on how to obtain continuous education credits for this. Here are our learning outcomes. So at the end of this, we would like for you to be able to name 5 psychiatric conditions that may lead to administrative separation actions, demonstrate the procedure and the steps required to put together an administrative separation packet, and ultimately that goes into the health administrative review system, which is an online system that we'll go over. You'll also be able to describe some specific rules related to post-traumatic stress disorder when you're putting together an administrative separation. So this would be an important caveat to understand. You'll also be able to describe specific Army policies, which we would recommend that you download and keep on files and review in order to have a full grasp of these important competencies so that you are able to be a productive member of your team and optimize the medical readiness of your unit. Finally, we want you to be able to demonstrate when you should be able to consider medical board over administrative separation. So this is why one of the fork in the road is, am I dealing with a soldier that needs to be separated? Am I dealing with a medical board separation, or am I dealing with an administrative separation? And you have to be able to know both in order to execute either of the two processes. And so do take a look at our other medical board video topic. Here are instructions on claiming your continuous education credit for this activity by going to this link. So if nothing else, try to download and keep these Army policies. And I'm going to show you where to obtain the MedCom policies. But for the AR, the Army regulations and the directives, you should be able to just simply Google those and obtain those. So you can pause the video and try to identify which one of these you don't have for your files. This is the Army Medical Department policy portal. It does require a CAT card access login. So I assume if you're watching this, you are a member of a military treatment facility, and you should be able to have access to this. So I would save this link for future use, but you can go in there and search for any of the medical department or Army Medical Command policies. So let's just highlight some of the things in probably the most important policy, which is specifically relevant to our topic today of administrative separation. One key element here is that this pertains to enlisted service members only. Discussion of administrative separations of officers is outside the scope of today's topic. So we're going to be focusing specifically on this, and this is AR 635-200. So this particular policy, as you see in bullet 1, it is all about how to come up with a judgment of suitability. And there are two essentially ingredients to whether or not someone is suitable. So one has to do with duty performance, and the other one has to do with discipline. So as we list some of the chapters within this policy, I will highlight that some of those chapters or some of the ways in which we separate soldiers may have to do with duty performance, and some of them may have to do with discipline, and those would fall under the misconduct chapter, for example. So that would be chapter 14 that we'll touch on in a little bit. And one of the key element in the role that the medical providers have, whether you're a behavioral health officer, you're a division psychiatrist, a medical brigade psychiatrist, or a civilian team member, is that often do not assume that your commanders, some of whom might be very new, and they may not necessarily understand, but if you're able to project a particular roadmap for a soldier that you are meeting, and perhaps you diagnose them with acute adjustment disorder, you want to be able to visualize and create a roadmap. And some of the things you have to be able to check before you get to sort of that end destination where you're submitting an administrative separation packet for that soldier is you want to ensure that the chain of command is providing counseling, retraining, and rehabilitation opportunities. And they have to be done well, and they have to have documentations for that in order for the administrative separation packet to go through. So that is one of our ethical and legal obligation, and our role in that is to ensure we communicate with commanders that Specialist Smith might be looking at administrative separation in the next 3 or 4 months, and I would like you to start counseling, retraining, rehabilitating the individual, and please document that. So that when the soldier will either respond to those interventions or they may not. And in either case, the commander, when they initiate the process, we have met all the administrative and legal requirements for that. So the end state is the reason for administrative separations to exist is it allows for a more rapid separation of a soldier. And here we highlight cost, administrative effort, and the negative impact that it has on the unit But in my experience, I've also seen that sometimes when a soldier joins the Army, it, they should have never joined the Army. In other words, it's just not a good fit. And being in the Army creates a significant amount of distress for them, which becomes a health issue for the individual soldier, which may also, besides having dysfunction at work, may also pose safety concerns where the soldier may be suicidal, might feel helpless, might feel stuck. And so ultimately, it's also good for the individual soldier to be separated expeditiously so that they can move on with their life. And the Army is able to, through its recruitment efforts, replace that soldier. So this is what I was referencing. And so when you hear the term chapter, it's just a chapter within AR 635-200 that specifically addresses a type of separation. So highlighting a couple of important points, as I mentioned before, it applies to enlisted personnel. Commanders must show effort to rehabilitate the soldier, and it must be documented. With exception of some of these chapters, specifically chapter 14, most of these administrative separation doesn't really have any administrative legal sequelae, and the individual soldier separated, especially under some of the behavioral health type of chapters, usually leave the Army without any issues as far as getting a dishonorable or type of discharge, for example. And then another piece to highlight, as you see the various colors, you as a medical provider, as a behavioral health provider, may be the one to initiate some of these. And so let's go over some of these chapters that are relevant. So 513 and 517 are essentially the same, except 513 deals with people with personality disorder that you want to administratively separate from the Army that have had less than 2 years in service. So most of the time, because of the various administrative burdens of the process, most people end up not falling into 513. So the predominant one that I would say, that you're dealing with 80+% of the time is 517. So this is the one that you want to become very familiar with. Download the 635-200 and go through this this chapter line by line. But this one deals with personality disorders, 2+ years in service, and then other behavioral health conditions. And so in your mind, when you look at behavioral health conditions from DSM-5, they belong in two different compartments. Compartment 1 is medically boardable conditions, and compartment 2 is administrative separation type of condition. So we'll talk about what those are, but the medically boardable conditions, if someone has dysfunction because of those, they need to be medically boarded, and so the administrative separation policy won't apply to them. But there are tons of other administrative separation conditions, such as acute adjustment disorder, for example, or impulse control disorder is another one that comes to mind, that are adjudicated through 635-200 through using 517, for example. As you see, the Chapter 7, fraudulent erroneous enlistments, even though it's there's a really high bar for this, and I have never seen it getting done. So proving someone's intent and is hard. This has to do with someone who should have never been allowed to come in, and they, you're proving that they were uh, essentially defrauding the government by either not disclosing or disclosing something untruthful. There are these other chapters. So the ones that you would deal the most with if you're working with in behavioral health is 517 and chapter 9, which has to do with alcohol and other drug abuse rehab failure. And then the rest, as you see there, for example, you'll see a lot of cases where you're going to do evaluations for people that have had some sort of misconduct. So someone that are positive for cocaine, for example, will end up with a chapter 14 separation. And they may end up getting less than honorable discharge in that. But even then, most of these do not end up with so-called dishonorable discharge. They might get discharge under honorable condition. And so that you see these other ones, the big ones to remember is 517 and chapter 9. Those are the most prevalent ones. So moving on to the next slide, and this is going to be my last slide, and then I'm going to hopefully prime some ideas and have you think about this case so you can pause and see what you would do next. And then I'll have Major Skiles, and she'll kind of go through step-by-step process of what we recommend you would do. And hopefully through her illustration using this vignette, you at least go from not necessarily understanding to understanding the process. What I do recommend is, if you are new to this process, is the next time you're confronted with someone who meets criteria for this, is try to go through the packet, assemble it, but then definitely run it by someone and get some coaching and mentorship on it. And I think after coaching on maybe one or two cases, you'll be able to do this very easily on your own without any guidance. And so, and then the final point is it's very important that we're able to do this because as you'll see with acute adjustment disorder, if we don't act in a timely fashion, acute adjustment disorder becomes chronic adjustment disorder, and then that is no longer an administratively separatable condition. It becomes a medically boardable condition. And so now a soldier might be miserable and feel completely helpless and hopeless. And now they have to go through a much, much longer process through a medical board. And I think we end up, have essentially done disservice to the individual soldier, to the unit, and to the Army as a whole. So there is definitely should be a sense of urgency when it comes to acute adjustment disorders, because the clock is ticking. So let me just share this case with you. So this is a 23-year-old married Caucasian man. He's active duty U.S. Army E2, and his MOS is 25 uniform, which is a communication specialist. He's only been in the Army for 8 months. TIS is time in service. He has had no deployments, and previously he had diagnosis of ADHD. So he comes to his first unit just a month ago, and essentially 2 weeks into the unit, he had to be escorted to the emergency department, and he was hospitalized for 3 days for suicidal ideations. He has history of 2 hospitalizations prior to enlistment for similar concerns. So this is a gentleman who unfortunately has been suffering from some sort of psychiatric illness for quite some time. And you might be thinking, probably should have never been accessioned to the Army. And I think you are absolutely right. But a lot of the accessions happen with self-report, and a lot of these soldiers really want to serve, and they end up not disclosing some of these things. And so here he is, first duty station, literally 2 weeks into the unit, and he's having significant challenges. So he's told his commander that he's homesick and just can't really do his job. He just wants to go home. Having crying spells, he talks about what a big mistake it was to join the Army. And he's been having a lot of panic attacks after learning when he showed up to his new unit that the unit is getting ready to deploy and his name is on the roster to deploy with the unit. Here's a key thing that I think I use a lot. So the soldier says he'll feel just fine if he could return home. And he's married, but when he joined the Army, his wife was not on board. So the wife says, yeah, you go ahead and serve in the Army, but I'm not moving with you. And so the wife is back home. He's totally separated from his support system. And I think everyone in the chain of command and other stakeholders would argue that he should have never joined. And the probability of him being able to tolerate 4 years of enlistment, if that's his contract, is very questionable. So the last bullet, I usually ask soldiers that, and this is actually fairly common in units. This is not an uncommon scenario. I usually ask them if I had a magic wand and if I could just turn you into a civilian again, as this had never happened, what do you think? How do you think you would feel? And most often, these acute adjustment disorder cases, the soldier or the patient usually said, "Oh yeah, I will just feel perfectly fine," and that's sort of my my magic wand question. And this is to kind of separate, maybe he's got some underlying medically boardable condition, major depressive disorder, etc. But no, he is just having complete difficulty adjusting to the new unit. So with that, I'm going to pass it on to Major Skiles now, who will discuss the case and essentially the procedure and steps to going from no admin SEP packet to submitting it to the end. So Major Skiles, it's all yours.
All right, thank you, Major Amin. I appreciate it. My name is Major Julie Skiles. I had the honor of serving with Major Amin up at JBLM and learned a lot from him. And we've kind of been working through these admin separations and med boards together for a couple of years. I think this is a phenomenal presentation and have used it in the past to help a lot of new providers as they kind of navigate the difference between the administrative separations and med boards. I'll go to the next slide and look at the things in red. All right, so the first one, he's an E2. So we know based on his rank that this is a new soldier. 8 months time in service kind of reiterates the E2. This is a newcomer. And then the fact that he's only been in the unit for 1 month and we're already seeing this level of concern about his mental health. And when you go down and you look at the history of 2 hospitalizations prior to enlistment, we can go back to that slide where we looked at chapters. So the first thought I hear a lot of people say is, this was a fraudulent enlistment. Most of the time I tell them, hey, we're not really going to get anywhere with the fraudulent enlistment. So we'll just use that to show the pattern of behavior for the soldier and strengthen the 517 case. I have not pursued a fraudulent enlistment so far in my career. And usually a 517 is just easier to go with. So one thing I'd like to emphasize with this is when you go down to the next bullet, the commander reports a soldier is homesick and is not able to do his job due to frequent crying spells, the panic attacks as well. So as a behavioral health officer, one of our primary jobs is being a subject matter expert for your commanders. And so often it's easy to get bogged down with everything that we're doing in the clinic and clinical care with the soldiers. But one of the most important things that we can do as providers is communicate with our commanders. Communicate with the commanders. They see what we don't see. They can give you different insight and input into what is going on with the soldier than what we see in our office. So the soldier may not tell us that they're having frequent crying spells at work, but that commander or that first line supervisor that is seeing that can often give us a different perspective on the soldier. And like Major Amin said, one of the biggest red flags for me is when a soldier tells me if I were just out of the military, I'd be all better. So that magic question, and they say it's the Army. All right, so if you can screenshot this, pause it, take a picture, whatever you need to, because this is the algorithm that will help you in determining whether a soldier is appropriate for the 517 or not. So when we looked at our objectives, 5 psychiatric conditions, that was one of our objectives that we were going to learn. And if you look on the right, on the left, the DSM-5 conditions eligible for administrative separation, adjustment disorder acute, right? That is probably the most common one that we see. They're having trouble adjusting to the Army, adjusting to a stressor in their life. That's the one we see the most of. Personality disorder is the next one. However, we'll get into it a little bit further. Personality disorder seems to be a little bit of a hot button topic, and we don't see that diagnosis as much as is probably appropriate. So you can look down at ADHD, you've got autism, and then you've got conduct, social communication disorders, factitious disorders, gambling, hoarding, intermittent explosive, paraphilic disorders. Again, those ones aren't as common. However, we can use those for the 517s. So you first look up at the first block, and it says the provider determines that a behavioral health condition, associated behaviors or symptoms significantly interfere with assignment to or performance of military duties or deployment. Right, so that's key. They interfere with assignment to or performance of military duties or deployment. Because we have plenty of soldiers serving on active duty that have ADHD or that have some of these other disorders, and they operate fine. So we're looking for the interference with assignment and performance. So drop down to the next one. The behavioral health condition is a significant contributing factor or the primary cause for their poor work performance, impairment, etc. So if no, bop on over to the right, and they're not, the ADCEP is not appropriate. If your answer is yes, then go down and we're checking, is the behavioral health condition eligible for administrative separation per MedCom policy 1901? And so we'll get more into MedCom policy 1901, but that is going to be your little Bible for administrative separations. If you're unsure, look over at your DSM-5 conditions that are eligible. And if it's not, then we're probably looking for an MEB, which is why if you have the time, make sure you listen to the second presentation as well on MEBs. If the answer is yes, go down to the next one. They've got a poor prognosis due to the severity of the diagnosis or treatment-resistant symptoms. If no, they're responding and we're able to get them back into the fight, then we're not going to give them an administrative separation. All right. If the answer is yes, then we're going down to, have we given them ample opportunity to overcome their symptoms? If the answer is no, then we have to give them that opportunity. If the answer is yes, then we are cleared, green lighted to go ahead with the administrative separation. So this is where we inform the commander. Again, going back to that communication piece, we submit the administrative separation packet to BHAR, and then we're going to give the commander the DA form 3822, and then they start their process on their end to go through legal. All right, so going back to the case example, we diagnosed him with adjustment disorder acute. So it does support the administrative separation, and that is not an MEB appropriate diagnosis. So do they have bipolar 1 or a psychotic disorder? No. So that supports the administrative separation. Then we go into, yes, there is impairment and limitation. Chronic symptoms, yes, lifelong. And that goes back to that piece. He's had 2 previous hospitalizations. So we're seeing the pattern. Is there a poor prognosis? Yes, we can see that as well due to those 2 previous hospitalizations, as well as the fact that he says, I'm not going to get better as long as I'm in the Army. So are we going to give him the opportunity for treatment? Yes, we're going to give him the opportunity, but the soldier may decline that. So that's why you've got to be determined over in the supports administrative separation. So what should we do? First thing is we're going to evaluate the soldier's current symptoms, history, and prognosis. So we're going to look at everything that he is endorsing, and we're going to document all of that. Impairment, identify the primary cause. Is it generalized anxiety disorder, or is it major depressive disorder, or is it an adjustment disorder? So in our case, the soldier's been very clear that it is the Army that is the significant reason for his impairment. That is the primary cause. So once again, we're looking at, do they no longer meet the retention criteria? They're not able to perform at work satisfactorily despite the treatment. And again, this is where we're communicating with command. And oftentimes I send a couple questions to the commander and say, hey, talk to the first line supervisor as well, asking them, you know, would you take the soldier to the field? How do they perform at work? What have you done at the unit to try and rehab this soldier? Right. So that goes into bullet 4, where you're informing the commander of the diagnosis, the poor prognosis, and then your recommendation for administrative separation. Part of this is the commander has to counsel the soldier and also has to agree to pursue the administrative separation. So oftentimes, like Major Amin said, a new commander may not even have heard a Chapter 517. So you're going to have to explain to them the process. You're going to have to explain to them from your viewpoint how the soldier is not going to get better, and essentially get them on board with this 517. If they decline or you meet resistance, in my experience, it's because the commander just doesn't understand the process or doesn't understand behavioral health conditions. And that's our job to help the commander understand that. So you're also going to inform the soldier. Very few times is a soldier unhappy with the determination. You e-profile them, so you put a profile into the system, and that also helps communicate with command as well. The DA form 3822, that's going to be at the end once you do your assessment and write-up. You're going to do the DA form 3822, and in the selection box, you're going to select 517 for the separation type. So when you do the entire packet, you do your assessment, you fill out all the documentation, supporting documentation, you are going to submit all of that through the online platform. And you can continue treating the soldier throughout the entire process. Once the soldier can get treatment from the time they step in all the way until they are outside of the military. And we support that all the way. Okay, so here we talked a little bit about how MedCom Policy 19001 is going to be your Bible for administrative separations concerning 513 and 517s. Read this thing over and over, you know, set it up on your computer with easy access to, and just refer to it anytime you have any questions about a 513 or a 517. So again, we're just reiterating the same thing. This is the most important policy for behavioral health providers. You absolutely read it. So what do they require? What do the chapters 513 and 517 require through this policy. We cannot skip around on this. This is what we have to do. So there has to be an evaluation by a behavioral health provider. You have to use the BHAR website. There's no other way to push a 513 or 517 through except through that website. The 513 or 517 has to be reviewed by the IDPH, the Installation Director of Psychological Health. And then if your soldier has deployed to a designated hostile fire or imminent danger pay area, the packet gets reviewed by the Office of the Surgeon General. So most people get scared by this and say, is it even worth submitting it? Honestly, it just adds a week or two to your timeline. I haven't had a packet kickback because a soldier deployed, all right? But it does have to go through them and they have to sign off on it. All right, when you look in MedCom policy 1901, if you're confused, has this soldier deployed to a designated hostile fire or imminent danger pay area? It includes an annex in there with all of the hostile fire or imminent danger pay areas. So this isn't just limited to Iraq or Afghanistan. You have to look through here and see if any other deployments match up to these hostile fire or imminent danger pay areas. It's going to have the dates that they have to have served in that location. But there is an annex to look for that answer. All right, so who can do the evaluation in accordance with DODI 6490.04 and MedCom policy 1901? So most BHOs in the Army are either clinical psychologists or licensed clinical social workers, but there are other people that can do it. Psychiatrists can do it, psychiatric advanced practice registered nurses, and then trainees. So most Army installations have the psychology and the social work trainees that can do this. It just has to be endorsed and co-signed on both the DA Form 3822 and the note. Okay, what has to be included in your evaluation? So when you do this evaluation, you have to go through the record review. So we've got on here Alta and Hames, but you've also got Genesis or other electronic health records, depending on what all is out there. So make sure you're looking through everything as far as their electronic health record goes. So you have to do a clinical interview within 3 months of recommending the administrative separation. This is where you sit down with the soldier and you do a full clinical interview. So in 19001, it'll tell you what you have to screen for. And so you have to screen for PTSD, depressive disorder, TBI, sexual assault, while in the military service, or any other behavioral health condition requiring an MEB referral. So those are mandatory. You can't skip those over. They have to be included. They have to be documented. So comorbid behavioral health conditions. So when you do this full evaluation and the soldier reports, PTSD, TBI, depressive disorder, or any other boardable behavioral health conditions, anything that could be used for an MEB rather than an administrative separation. We can, if the soldier falls below medical retention standards and we have to refer an MEB based on the PTSD, depressive disorder, or any of the other conditions that can be used for a med board, we cannot do the 513, 517 any longer. That has to be switched over into the MEB lane. All right, so comorbid behavioral health conditions. This is another one that a lot of people get caught up on. So if a soldier screens positive for PTSD, TBI, depressive disorder, or any other behavioral health condition within the last 2 years, that we think, oh man, they screen positive for PTSD, we've got to send them to the med board versus administrative separation. What we're looking at is if it's not currently active, or if they have PTSD, but they also meet retention standards, then we can proceed with the 517 or 513. Right? So it's a little bit tricky, and this is why it's so important, that communication piece. If you have questions ask another provider in the clinic, ask somebody else that could maybe look at it from a different vantage point and let you know if they think the administrative separation is appropriate or if it should be kicked over to the med board. All right, so the exception. Of course, we'd never make it clear cut, black and white. There is an exception, and it's service-related PTSD. All right, so we put this one in big and bold. Make sure you pay attention to this one, the PTSD exception rule. If there is service-related PTSD, if it's ever been diagnosed, when you scrub the electronic health record and there is service-related PTSD, we cannot recommend an administrative separation until after IDES finds the soldier fit for duty, right? So then it kicks over to the med board lane. IDES has to say they're fine, and then we can do the administrative separation. But this just gives us a little bit of a pause button, the service-related PTSD. All right, and this comes about because we don't want to inappropriately separate somebody on an administrative separation that should be getting a medical board. All right, so screening tools. This one has gotten a little bit more complicated with COVID. So we've had to be creative in how we screen our soldiers, but usually we will use BHDP. And so you can get your PTSD screeners, depression screeners, sexual assault screeners, TBI screeners through BHDP. You can also use it through hard copies, and your policy 19001 will give you those screeners that you can use as well. So if they do have a positive screen, then it just requires a clinical evaluation to kind of tease out what is going on with this soldier and to establish the correct diagnosis. So we use the example of TBI. If the TBI screening is positive, but the clinical interview reveals a lack of any concussive event, you don't have to refer them further. However, if they do, then you can send them over maybe to the TBI clinic, to whatever specialty they need to get further evaluation. So BHDP is linked to the BHAR website. So PTSD, TBI, depressive disorder screen, those will be automatically uploaded. And when you go into the BHAR website, there's little check boxes that you can say, this is included in the electronic health record, those screenings, etc. You don't have to upload a hard copy of the PTSD, TBI, depressive disorder screens unless you did not use BHDP. If you use those paper copies, then those need to be uploaded as well. Sexual assault is not included in BHDP, right? So there's a 3-question screening tool. And like I said before, it's included in MedCom policy, and you have to use it, you have to scan it, and you have to upload it into the BHAR website manually, right? So your packet will get kicked back if you do not screen them for sexual assault. This is the sexual assault screening that's included in policy 19001. So it's just yes, no, yes, no, yes, no. And then if they do screen positive, this is where you're going to ask further clarifying questions and document it. So here we dive in a little bit deeper into sexual assault. So what you have to include in your note is whether or not the screen was positive or negative. So if positive, you indicate in your clinical opinion whether the sexual assault contributed to the administrative separation. You also have to indicate whether or not the assault was restricted or unrestricted. So say you have a positive sexual assault incident history. That in and of itself is not going to prevent the administrative separation from going through. They can still get the Chapter 513, 517 if they screen positive for sexual assault. We're going to go into a little bit further in the next slides about what we have to do when you do have a positive sexual assault history. But really what you're determining is if the sexual assault was a contributing factor. So we were talking about positive sexual assault incident history and saying that it does not prevent the administrative separation from going through. You're just looking for whether it was a significant contributing factor to the reason for separation. All right, trying to get to the next slide. Major Amin, maybe you can hit next slide for me. All right, there we go. So let's look at an example of sexual assault case that does require an MEB referral. So the soldier with PTSD, personality disorder, as well as service-related PTSD from sexual assault must be found fit for duty by IDES. So that goes back to that slide where we're looking for the service-related PTSD. So a soldier with a personality disorder and other specified trauma and stressor-related disorder, which is subthreshold PTSD, due to that sexual assault should be referred to IDES if the symptoms are the primary cause of impairment and that the soldier no longer meets minimum standards of fitness due to their behavioral health condition. So this is where we're going to pop them back over into that MEB and refer them to IDES. Next slide. All right, some examples of where sexual assault case examples that are appropriate for the administrative separation. So if you have a soldier that has a personality disorder as well as a sexual assault history, what you're looking for is if the personality disorder is the primary reason for the impairment, not the sexual assault. All right. And then a soldier can have a sexual assault and be chaptered under any of those chapters. If you go back to that previous slide, you've got chapter 14, 13, 9, 8, any of those. That soldier can be separated with no behavioral health treatment for that sexual assault. Next slide. All right, here's another case example of sexual assault case where they are appropriate for the administrative separation. So they were sexually assaulted, they have a behavioral health diagnosis, but they did not reach the threshold for MEB. And they're pending that administrative separation for misconduct or poor performance. If you as a behavioral health provider feels that the condition is a contributing factor to the behavior resulting in the administrative separation, what you note on DA form 3822 is that it was a mitigating factor. So you don't include in there sexual assault unless it's unrestricted. So pay attention to that, you know, maintain your soldiers' confidentiality, respect that restricted reporting. And this is an example of what you could do in this situation as far as noting it on the 3822. Next slide. All right, so this is the DA 3822. And so you check the box. There's very little that you are going to write on the 3822 that you're just going to have to wing it and write something in there. It's very cookie cutter, check the box type of thing. So you can check the box to let the commander know that a behavioral health condition should be taken into consideration during the administrative separation. So it's not preventing the administrative separation from happening, just that they should take that into consideration. Next slide. Okay, so behavioral health conditions as a mitigating factor. So you have to annotate that a sexual assault screening did occur. It's something that is mandated in MedCom policy 19001. You're going to check that on your DA 3822. And just that it was done. You don't have to indicate whether it was restricted, unrestricted, positive, or negative. All right, just endorse that the screening occurred. So where you will
clarify what happened, and the unrestricted, restricted, positive or negative is in the electronic health record. And then you're also going to annotate in your note whether, in your clinical opinion, the alleged assault impacted the soldier's behavioral health condition or contributes to the administrative separation. If it's an unrestricted report, you may document this on the 3822. Next slide, please. Okay, so in summary, sexual assault. So we know this is a serious subject for the Army. We know it's kind of a hot topic currently, as it should be. So these are the documentation considerations, right? So you have to indicate that it was completed, right? And you check the box on it on your 3822. Again, if it is restricted reporting, do not reveal the screening results on the form. This is a quick way for soldiers to lose trust in the system, in behavioral health, is by violating their privacy. Unrestricted reporting, if you find that it was a factor in the administrative separation, then you can check that box for the commander to consider. Next slide, please. Okay, personality disorders. Once again, service-related PTSD, look for that in the diagnosis. And Major Amin covered the soldiers less than 2 years time in service, 513, more than 2 years time in service, 517. And we talked a little bit about the fact that we often fail as behavioral health providers to make the personality disorder diagnosis. If the soldier meets the criteria for a personality disorder, diagnose that and document that. And then we just clarify that you can use other specified personality disorder when it's clinically indicated and not met for the common personality disorders. And document that clearly. Don't just put, borderline personality disorder and drive on. Really annotate that and explain and justify your diagnosis in that electronic health record. Next slide. All right. When you do diagnose for a personality disorder, it does require peer corroboration. So a second behavioral health provider corroborates that personality disorder diagnosis in order to reduce the risk for misdiagnosis. And again, this shouldn't be anything that scares you away from diagnosing personality disorder. If the soldier meets the criteria, they meet the criteria. And you're just going to have that second provider review your note and co-sign it if it's a clear diagnosis. So you don't have to do psychological testing. I know some people do, and that's fine as well. But that psychological testing can serve as the second provider. And then your third option is the IDPH review of the packet can serve as that second behavioral health provider. Next slide. All right, so this is our most common one, adjustment disorder. The acute adjustment disorder is the symptoms are interfering with their military duties, even after you've given them a reasonable duration of treatment. This is where you're also going to get your input from the command team. They are going to be the ones to tell you how they function at work, how they are unable to function at work, and the evidence of the impairment. So the commanders also have a role in this administrative separation, in that they have to also be counseling this soldier on what they need to do in order to rehabilitate, because we are trying to give soldiers an opportunity to remain in the military service. However, you can still provide a soldier the opportunity for treatment, and they can decline treatment. And so if you document that the soldier says, I'm declining treatment, and they do not want it, you're fine to go ahead and recommend that administrative separation. And then once again, we'll put in there, it cannot be pursued with the service-related PTSD. Next slide. So the acute adjustment disorder, that's where we're looking at a 6-month timeline on it. However, they can have multiple separate acute adjustment disorders, each with different identifiable stressors. So we're not looking at a chronic adjustment at that point. You know, we're looking at several different acute adjustment disorders, and you can go ahead with an administrative separation at that point. Once it changes over to chronic adjustment disorder, then you no longer can do the administrative separation. You are looking at a medical board for that soldier. So this goes back to the importance of good documentation in the electronic health record and allowing a behavioral health provider to clearly make a decision on where this soldier is and what's appropriate for them. Next slide. Okay, this is where we talk a little bit about the persistent chronic type of adjustment disorder. So the chronic is made when the stressor is persistent and recurrent, it requires extended or recurrent hospitalization, interferes with duty performance, and it lasts 6 months or longer, right? So when we are looking at administrative separations, we're under that 6-month timeline unless we're looking at different instances of acute adjustment disorder. For chronic adjustment disorder, you're looking at the soldier has to meet the diagnostic criteria throughout the entire 6-month period. So once they hit this, they are more than likely reaching MRDP, and you're going to refer the soldier to the med board process. Next slide. All right, so this is where we're kind of looking at the difference between should I be the one to recommend or should somebody else? All right, so usually, and when we're talking behavioral health officers, there's usually 2 of us in a unit. So if my counterpart has a soldier that she's been treating for a while and she thinks they're appropriate for a 513 or 517, she often kicks that assessment over for me to do it so that it doesn't appear as though there's a conflict of interest, and I do the same for her. However, you're going to be working oftentimes in a clinic with multiple providers, and use those people for to do those assessments. Okay, so the dual role, that's what we're talking about, the treating provider and the administrative evaluator. Sometimes there's absolutely no choice, and you have to do that dual role, but avoid it at all costs. Usually there is somebody that can do that assessment if you are the treating provider. Next slide, please. All right, so we're going back to the case example. All right, so we've already evaluated, we've done the impairment, we have reached the administrative MRDP, we've informed the commander, and so we've informed the soldier, we've done the e-profile, the DA form 3822, and the 517, and then the BHAR packet. Next slide, please. So the 3822 has its own policy, and it's a phenomenal policy in that it tells you exactly what to write for each separation, or whatever you are using the DA 3822 for. If you're doing an assessment for a drill sergeant packet, there's a copy and paste option from that policy that you can put the appropriate language in that DA 3822. So here's some templates. You can find them at this link. I encourage you to use that. It just makes it easy and makes everything standardized for the 3822. Next slide, please. All right, so we're going to talk a little bit about the BHAR packet. Next slide. All right, here's the link to get onto BHAR. You're going to go ahead and create a profile for yourself, log in, and then you're going to go to actions. That is your starting point. Next slide, please. All right, so these are your actions when you're in BHAR. You're going to create a new packet. The type of separation, you're going to put chapter. So when you're in BHAR as well, the intent is that all 3822s for behavioral health chapters are uploaded in there. So you'll see options for chapter 13 and chapter 14. So you are going to select the 517 chapter, and then you're going to create it. It's going to require you inputting the service member's social, not DOD ID number. And then you're going to upload all of the documents. You're going to do the 3822, the sexual assault screen. If you have done your screenings through BHDP, you can just check the box in saying you've done those. If you did them hard copies, then you're going to scan those in as well. And then depending on installation, some installations have different requirements. So I'm here at Fort Hood and we type up a memo for the IDPH, and that's also included. We also include a Word document of our full assessment for the 517. So you're going to have to check at your installation what exactly they need and what they don't need. But you'll see in BHAR what exactly they want in the check boxes that you're going to need to complete. So you're going to submit it, and then the IDPH will review the completion of the packet, and they'll let you know if they need more documentation or not. Next slide, please. All right, so if your IDPH concurs, if your soldier has deployed to one of those hostile fire danger areas, then it's going to go to OTSG for review. They can go ahead and concur, and they'll sign that 3822 and send it back to you, and then you are responsible for getting that back to command. If they deny it, they're going to close that out, and they're going to say that no, the 517 or 513 is not appropriate, and that kind of ends it. You are going to either move to a med board, or you're going to move to whatever other type of disposition you need for the soldier. Or they can request more information, and then you carry on the same way and either get approved or denied once all of those are in. Next slide. All right, so I will turn it back over to Major Amin to close us out. We really, truly appreciate you listening in to our presentation, and hopefully you've got some good information. Absolutely feel free to reach out to me on Global. I do a lot of chapters, med boards, and 513s, 517s. So feel free to ask me any questions that you may have concerning the process or any products you'd like as well.
Thank you, Major Skiles. So I think if you are someone that is new to this entire process, this could seem overwhelming. And I want to take a few minutes just to kind of summarize the whole thing. So in the Army, if you have a soldier who is not able to function, there's, and we try to rehabilitate that soldier and they're still not able to function, then we have systems in place in order to disposition that soldier to civilian life and bring someone else on board. And so there are various mechanisms. One avenue is medical, and another avenue is administrative/legal. If someone is having dysfunction due to misconduct, then legal channels take over, or administrative channels take over. If someone is having dysfunction due to a medical condition or behavioral health condition, then it could be either administrative or medical channels, right? And so in your mind, when you have a patient in front of you in the behavioral health settings, you have to ask yourself, okay, is this individual having dysfunction, and have they had sufficient amount of interventions, and do they have a fairly poor outlook in terms of recovery and return to full duty? If you kind of check those mental checklists, then you have to ask yourself, does this individual have a medically boardable condition? And as we highlighted, pretty much everything in DSM-5 is medically boardable condition, with the exceptions to that, which was the list of conditions that you saw, things like personality disorders, things like adjustment disorders, impulse control disorders, all those other things that were listed there, along with failing substance abuse rehabilitation, which would be Chapter 9, for example. And so those would be the medical side of administrative separations. Then there's misconduct stuff like Chapter 14. So in order for us to administratively separate an individual soldier as compared to medically board them, it has consequences for the individual soldier. So there might be, if you end up receiving a medical board, there are financial consequences for that. For example, if you get a medical board discharge, then you may be qualified for various type of healthcare, as well as financial money, essentially. If you receive an administrative separation, say a 517, usually you just, there's really no benefits associated with that, no healthcare benefits or financial benefits. So because of that consequence for an individual human being, there are checks and balances in place, right? And there are specific procedures we have to follow. So once we determine that Specialist Smith needs to be administratively separated under 517, then the burden is on us to say he or she does not have a medically boardable condition, and rather this is only an adjustment disorder issue or personality disorder issue. So that is one piece that where we have to show that they do not have a medically boardable condition, or if they do, such as PTSD or depression, that the dysfunction is not stemming from that medically boardable condition, but rather an administratively separating condition like adjustment disorder. There's also additional checks and balances, and this is sort of a historical journey where PTSD patients with PTSD were being administratively separated because they're having anger problems and they're causing them misconduct and so on, and so they were separated, and they lost out on all of that, all of those benefits that I mentioned. And so essentially it was a disservice to those individuals who had served their country. So now the administrative process and the references that we mentioned makes you go through that entire checklist to make sure that we are not administratively separating someone who deserves to be medically boarded, essentially. There's also an emphasis on not causing harm to people who suffer sexual trauma, military sexual trauma, for example. And so as Major Skiles walked you through the procedure, you essentially are doing clinical assessment, and you want to make sure that you do it in a way that is fair and equitable and non-biased and objective as humanly possible. So I think that's the overall intent of this. And so one of our goal in this is we want to make sure that we are not administratively separating someone who should be medically boarded. So medical board always takes priority over administrative separation. And you can learn more about medical board piece in our other video lecture. Finally, one other comment I wanted to make, we reference this DA 3822 if you're new to all of this. So that is just an administrative form, and it conveniently has various kind of checks, boxes that you can check off in order to communicate with commanders, as well as use that form for executing an administrative packet like this. So with that, I will see if Major Skiles has any additional comments before we end this topic today.
No, sir. I appreciate working on this with you, and I look forward to doing more work in the future. Thank you.
Thank you very much. Bye-bye.